Hello, everyone. I'm Siri Vaith, Executive Director of CFRI, and I welcome you to CFRI's second question and answer session with Dr. Rick Moss about cystic fibrosis and COVID-19. And because information changes so quickly, I do want to say right from the start, today is Wednesday, April 1st. This is an extraordinary time in our lives and one filled with uncertainty. And as I said, information is changing rapidly. So we hope to be your partner throughout this process and help you keep informed. And I really want to thank everybody who submitted questions for Dr. Moss. Before we jump into the questions, I do want to remind people that CFRI has a lot of programs and services, many of which may be helpful during this challenging time. And I encourage you to go to our website to see those programs, including our support group moderated by Dr. Lisa Scher to cope with anxiety and depression that's been triggered by COVID-19. And again, I have to note that the information presented in this recording should not be used for medical advice, diagnosis, nor treatment. Please consult with your physician before making any changes to your healthcare plan in relation to COVID-19. So now on to the questions. For those of you who are watching this for the first time and don't know Dr. Moss, we are so grateful to him for being such a friend to the community and keeping us informed on very specific CF questions in COVID-19. Dr. Moss has made major contributions in the international field of CF in both clinical care and research. He is the former director of the CF Center at Stanford. He's professor emeritus there. And again, just so fortunate that he is here to help keep us informed. So thank you so much, Dr. Moss.
Thank you. Good morning.
So we had many questions submitted, starting from the top. What is the current situation for the US on the number of cases and deaths? And do you know where in the US are the highest clusters of cases?
Yeah, well, we're still on the rapid exponential curve going up towards an apex. We have to remember this is a virus that human beings have not seen before 3 months ago, and we have no existing immunity. So it just spreads to whoever comes in contact with it. Now, most people luckily don't get sick, but about 20% who get infected do get sick and need to be hospitalized, and about 5% need intensive care. So it is a serious illness. It's definitely more virulent than the common seasonal flu, for example. Right now, I checked the figures this morning. We've hit 200,000 cases in the United States. We are the epicenter of the disease on the planet. There have been almost 4,400 deaths as of this morning. Here in the state of California, we're closing in on 9,000 cases, and there are about 184 deaths. For comparison, New York, which is the biggest center in the country, unfortunately, about 85,000 cases now, and New Jersey another 20,000 cases. So the New York metro area is the biggest hotspot. But these new centers have been cropping up mainly in different cities that reflect travel patterns and person-to-person spread. So now places like Detroit, Louisiana, New Orleans, Atlanta, most major cities. The first city that was hit in the US, in Seattle, and Washington state more generally, is showing some evidence of bending the curve at this point. So that rate of increase is starting to slow down. We've also seen that here in the Bay Area, in Northern California, which followed very closely and had the first stay-at-home order in the country several weeks ago. So there is evidence that this is working, but boy, it's going to take a long time, and there's going to be a whole lot of suffering on the way.
Are there any known cases of CF patients who have COVID-19? I guess I should say, I know that there is that boy in Tennessee, the only one that I had heard of, but I don't know if you've heard of other cases, and whether you have heard anything about how that is presenting for people with CF, and is there any change in symptoms and or protocol to treat it?
At this point, the cases are still, the only ones that we know about generally are those that are in the media or on social media. For example, I know there's a boy in England who was in the mainstream media there, a story on him. He's recovering even though he had pretty advanced CF lung disease, which is great news, and a couple cases in the States, but no real effort to collect those cases in any systematic way at this point. And that's understandable. People are overwhelmed with the general issue of the population at large being at risk. So we do know from studies primarily from China and Italy, and now also some other countries, is that chronic lung disease is one of the major risk factors. So although CF has not been singled out in that chronic lung disease category, most of those cases are older people with COPD, which has a lot of similarities to CF. You can think of CF as a kind of more aggressive, earlier onset form of COPD, then it's easy to assume that CF is in that high risk category also, but nothing systematic at this point that I know about.
I know the last time we had a question and answer, you had a great thing about tracking fevers. And I thought it would be good just to remind people, because again, so many symptoms of CF might mimic potential COVID-19 symptoms. People are having horrible allergies right now. Of course, everybody wants to avoid medical centers if possible. So could you just reiterate what people should be looking for, thinking about before they decide to get tested?
Yeah, the CDC has a very nice downloadable page on this called CDC Care. Care stands for check and record every day. And that is a fever chart. And I think it is useful for folks with CF to do this. The reason being that fever is the most common symptom of COVID-19 infection, along with shortness of breath and coughing, which of course are part of CF. But most people with CF don't have a temperature if they're not experiencing some exacerbation, whether it's caused by COVID-19 or the regular CF bacteria or flu, any of the things that can cause you to get sick with respiratory infection. So if you take your temperature at the same time every day and make sure that you don't artificially influence that by some means, and take your temperature orally, and if the cutoff is above 100.4 degrees Fahrenheit, which is 38 degrees centigrade, that is a sign that you have a fever. So at that point, you should make a contact with your healthcare provider.
Thank you. And Dr. Moss kindly shared that CDC PDF, and we do have it on CFRI's website now under our COVID-19 resources. So please, everybody, check that site. We've all heard about these very hard decisions being made in Italy, with so many people with COVID-19 requiring ventilators, and the number of ventilators not meeting the tragic demand. What's happening in the US with this issue, and will there be issues for people with CF should they be faced with this horrible situation where there might be a lower priority for receiving a ventilator?
Yeah, well, the limitation on equipment in general has been a big issue in the States, and that applies to test kits, personal protective equipment like masks and gowns, various things that healthcare workers in particular need. And as you mentioned, ventilators. So if somebody is hospitalized, they're usually going to be hospitalized for symptomatic treatment. And since the main effect of this disease is to affect the oxygenation, many of these folks need supplemental oxygen. So you might get admitted, and if it's a mild to moderate case, just to get supplemental oxygen. People with greater need for oxygen may need assisted ventilation, and that might be either non-invasive or require being an intensive care unit with intubation and assisted ventilation. Those ventilators are a precious resource, and the news has been filled with accounts of people asking for it, ventilators, shortages being predicted. In most cases, except for New York City, there's adequate ventilator equipment now, but that's not the issue. The issue is what happens next week, the week after that, the week after that, until we hit the apex, which is likely to be sometime in mid to late April or early May. So that's the real issue. And in that regard, we're starting to see things like cooperation between hospitals and between states to shift ventilators around, to flex them. The United States does have a strategic stockpile, so the federal government has a role, and it has been giving some ventilators to some localities, but coordinating that is very difficult. And it's been complicated by some politics at the national and state level also, part of our system. So all those things are at play in terms of who gets the ventilators. And some private companies now I know are being tasked with going from making cars to ventilators and various other things, rocket engines to ventilators. Very interesting shifts that are occurring in the private sector to help out. So we'll have to wait and see, but that is a big issue now. And like I say, right now there's no shortage either locally or in the state. There are localities in certain places in New York where there is a ventilator shortage.
And I have heard that different state emergency plans actually take this scenario into consideration. Who knew this would be thought about years ago? In which there are some criteria about people in lower lung function in terms of prioritizing if that were the case. Is this something that people with CF should be fearful of?
I wouldn't use the word fearful. I would use the word alert to and active about, in terms of being in touch with your providers and also with your representatives in the government at the county, state, and national level. There are guidances, and I was happy to see recently two of the leading medical journals in the United States, the New England Journal and JAMA, both with significant articles about the ethics of rationing, especially with regard to ventilators. And they came up with similar recommendations. These represent pre-existing recommendations to not exclude people based on a category of a disease. It's much more individualized than that. And the considerations involved include some kind of calculation about expectation of how much life would be lost if someone lost their life because of lack of a ventilator. And so these are very complex issues, but at this point, I think the need is to make sure that hospitals and professional organizations stick to the expert advice from bioethicists who have come up with nuanced recommendations about how to use this precious equipment.
I thought it was interesting that the article that you shared with me, the JAMA article, which we will post the link on our website for people to see, but I thought it was fascinating that it really used the same type of framework as the lung allocation score for transplant.
Yeah, thank you for bringing that up. It's really, and I think the CF world can be pretty proud that once again, we've led the way. The lung allocation score for lung transplant is the model that is being used to come up with the most, what's the right word, most ethical way to ration ventilators if we have to do that.
Let's see. Somebody asked, is there any data or any studies you know of on CF carriers and the outcome of COVID-19?
Yeah, not that I'm aware of. That information is generally not collected. For example, the CF Foundation Patient Registry does not include any data on parents, carriers, others in the general population who may be carriers. Carriers are considered to be healthy people, and we just don't have any information on that. It's possible in the future that people will be able to look at CFTR function in relation to what happens if you get exposed, but that's a long way off. Right now, we're in a triage situation scientifically to just try and cope with the needs of supporting people and finding new treatments and developing a vaccine.
It seems like, and of course there's all sorts of discussion about what do we really know from China, but they are ahead of us. Obviously, they have flattened the curve. Things have changed for the better. How much of that information is shared with scientists and clinicians and researchers here in the United States and Europe?
A large amount of what we know about the virus has come from China. And what you see are articles either posted before they're peer-reviewed or then later published, somewhat later published in peer-reviewed journals from various groups in China based on where they're working, their hospital or university. And there are many such papers out now from China. So a lot of what we know about the disease actually has come from China. There's been some question about the accuracy of the data in terms of the government figures that are put out. And that's really something that is open to question. I do know that the World Health Organization accepts those data as reliable and lacking any other information to the contrary. So yes, from what you and I have read about, they have flattened the curve there. They've done it through a very draconian imposition of total lockdown on tens of millions of people. Some people have been basically confined to their apartment for 7 or 8 weeks. They're now just starting to lift these outside the main hotspot, which is the city of Wuhan, and we'll see how that goes. There's quite a lot of concern that they will have another resurgence of the disease, and part of their approach to this has been to close their borders to outsiders coming into China. So they've now banned people from going into China from anywhere else, which is a really ironic reversal of what happened just a few months ago when the whole world said, hey, it's a Chinese problem. They're exporting it to the world. Well, now they're protecting themselves from the rest of the world. Strange world we're living in.
Yeah, it's crazy. So there are the papers. I know you had mentioned, I think the last time we spoke, about this incredible Facebook page of clinicians that are sharing information from around the world.
Yeah.
And so I know some of that's not going to be, papers. A lot of it, I'm assuming, is anecdotal information from people who are in the field. And do you know whether clinicians here in the US are tapping into that anecdotal information to guide their care model?
You're right. The Facebook physician page on COVID-19, I think now has something like 150,000 members.
Wow.
So it's just this fire hose, and it really is the best and worst of social media in general. So you get everything from anecdotes to really expert analysis of published papers. It's the whole thing. So it's really hard to pick out the wheat from the chaff, but many people are using it to trade ideas, particularly in terms of their practices to reduce the rate of infection in healthcare workers and treatments. Those are probably the two biggest areas where anecdotal experience comes in. So things like hydroxychloroquine treatment are hot topics, masks and other protective equipment, shortages, getting them, so forth and so on.
Well, and actually, you said about the masks. Yesterday, the CDC said they're probably going to change their recommendation that everyone going out should wear masks, not N95s, but that even homemade masks will be better for, I'm assuming that is to keep droplets in, right? With the assumption we will protect everybody else from us.
Yeah, I checked their website this morning. Nothing announced. It could come later today or tomorrow, but they are definitely reevaluating their recommendation, which was initially just to recommend masks be preserved for healthcare workers. The experience in Asia, in several places, not just China, but also places like Hong Kong, Singapore, Taiwan, South Korea, Japan, Asian countries in general, it's kind of an interesting cultural difference. There's not as much of a stigma about wearing masks. People are less reluctant to do that. And there's some opinion that that's been helpful. Just in terms of thinking about how the disease is spread, which you said is absolutely the reason. It would be on the basis of not assuming that you're not infected because you don't have symptoms. We now know that up to a quarter of the people in the US, and there's a study now from Iceland where they found up to 50% of infected people are asymptomatic.
Wow.
Or pre-symptomatic when they're looked at. So with that very large number of people that may be spreading the disease unknowingly, the idea is, hey, let's assume that I am a problem. You're not the problem, I'm the problem. So if I go out, maybe I should wear the mask to protect you. And I think my guess is the CDC will move on that. The reason they haven't before, I think, has a lot to do with the shortage problem. And so that is still being addressed in many localities, and that's why there's all this interest now in self-made masks, which may have some effectiveness in those larger droplets getting out. They won't solve the aerosol problem, but they do help in terms of the droplet problem. So I think it's, in general, probably now a good idea to consider wearing a mask when you're outside.
So you said about the aerosolized problem. How big a problem is that in terms of when we speak, when we cough? How big are the droplets? I know we can't see them with the naked eye, but what's the difference between something that's heavy enough to drop versus be aerosolized and float?
Yeah, I think this is one of the biggest areas where there's some ambiguity. Most people have tended to view the transmission mainly from droplets, which don't stay in the air. You cough, a droplet is larger than 10 microns. That's a size that's used. It's still invisible, but it's larger than some things. And it's mainly water, and the virus may be in the water droplet. And if you sneeze or cough and maybe even breathe, some droplets might come out. It's thought that those settle pretty quickly, within seconds to minutes on a surface. And then the transmission problem is touching and touching, right? Aerosols are different. Aerosols are smaller. They can stay in the air a longer time, under 10 microns. If they're smaller than 5 microns, they can float all the way into your air sacs, the alveoli, which is where the disease is really taking place. And several studies now have indicated that some COVID-19, if it's aerosolized, can stay in the air for at least 3 hours, which is a kind of scary thought, right? Mm-hmm. So that's a good reason to have good ventilation, to love the great outdoors, to stay isolated indoors if you don't have access to that, and avoid large groups of people where the chances of aerosolized particles go up. But there's precious little hard data on how infectious those viral particles are. So this is the great unknown. In other words, you could have the virus particle wafting through the air for 3 hours, and then you breathe that in, but is that really going to infect you? Has the virus been inactivated in that period of time? We don't have the answer to that particular one. And the answer to that really has to come from seeing the infectivity of aerosolized particles. The NIH study did indicate that it is potentially infective up to the 3-hour limit that they did that experiment. But they created a large aerosol cloud, which may not resemble what happens when people breathe or cough. So to my mind, there's still a lot of ambiguity, but caution would say to me, you should err on the side of being as careful as possible in terms of the aerosol issue.
And sorry for my naivete, but literally coughing, there are particles that are as small as nebulized particles. How are they becoming so small? Is it from speaking, coughing? Like I know in that study, it was like a machine, right? That nebulized it, but
yeah.
What are we doing that's making it so small?
Most of the studies of coughing focus on droplets. And if you go back, it's interesting, we in the CF world have a long history of this, right? That's where we got the 6-foot rule, because of coughing studies looking at the transmission of bacteria like Pseudomonas, right? Which can also be in these droplets. So those, as we know, don't travel very far and will settle down. Viruses are much smaller than bacteria. A fraction of the size, a tiny fraction. You can fit hundreds of virus particles in a single bacterium. So they may be much smaller aerosol particles, and that is worrisome. And I think one of the things that is also of concern to healthcare workers is that aerosolization procedures are part of medical care. So for example, if someone needs to be intubated or if someone needs a bronchoscopy, that's an aerosolization procedure by the nature of the medications that are used and the instruments that are used. So we know aerosolization is occurring with these medical procedures. One of the reasons I think healthcare workers are at high risk is because it's now been discovered that some of these aerosolized particles will land on the protective equipment. And then when people go to doff the equipment to take it off, they can re-aerosolize the particles as they're doffing the equipment. So things like staff rooms and changing rooms in hospitals may be potential hotspots. This is a great concern to healthcare workers in particular, but also to the patients that have to come into the hospital for treatment, and anyone else who's working or moving through that environment.
Yeah, and then you're hearing these just nightmare stories of medical care providers being told to reuse the equipment and the gowns because there just simply is not enough.
Right, and I've seen the videos. You may have also people cutting up garbage bags and using that as protective equipment. It's unbelievable the things that people are being forced to do to try to protect themselves. And we do know from European experience as well as China that there's a very disproportionate amount of illness and morbidity and some death from healthcare workers being exposed to these situations, which I think involve aerosols as well as droplet issues.
And at this point, it just seems you almost have to assume when people present at urgent care or emergency rooms, you know, that everybody needs, it seems like earlier, it was only after somebody was presumed to have it and possibly tested that all the protective gear was going on. So we need so much more of it. It is stunning to me just that we could have this shortage of the most basic things for patients. So we had a question from somebody. A new study finds COVID-19 can cause heart injury, even in people without underlying heart issues. What organs are most affected by COVID-19, and is there any known chronic damage?
Yeah, the main organ outside the lungs that has been implicated has in fact been the heart, and it's not clear at this point if that's secondary stress on the heart or actual infection of the heart. There's some evidence that the heart itself may be infected. The receptor is on blood vessels and so the cardiovascular system might be directly affected. We don't know that much about that, except from clinical reports that cardiomyopathy has been noticed in a surprising fraction of critically ill patients with COVID-19. So that's disturbing also.
Mm-hmm.
What was the second part there?
Just about, it's probably too soon to know, but is there any known chronic? So I'm assuming that means ongoing residual damage.
Yeah. I think this would apply mainly to more critically ill patients who develop what's called acute respiratory distress syndrome. So this is some portion of that 5% of hospitalized patients that need to go to the ICU. If you develop that, there's survival is problematic. Only 25–50% of patients will survive that. People who do recover from ARDS usually do have chronic lung problems afterwards. Short of that, we can hope that the viral pneumonia resolves completely, but we don't have enough follow-up data to know at this point.
Wow. Let's see. For individuals with CF, what do you recommend we do to boost our immune systems?
Yeah, great question. I think it's important while sheltering at home to make sure that you continue to get enough exercise, extremely important, and have good nutrition. So all the usual dietary recommendations need to be continued. Your enzymes, your extra calories, your fat-soluble vitamins, extra mineral supplementation, whatever your usual CF care regime is. I don't think I'd add much on top of that except to make sure that besides trying to protect yourself from infection, to make sure you're getting enough exercise. So yes, you do need to get out unless you have some kind of in-home gym situation. Get out there and do some exercise, hopefully on a daily basis, and make sure your nutrition is maintained. Beyond that, there's really nothing in particular. I know some people, again, this gets into the anecdote area, are proposing zinc as one of the components of treatment. Unproven, but it's out there. So you might come across that in social media.
And are there any vitamins that people should not be using who are on the CFTR modulators? Is there?
I don't think so. No, I don't think there's any need to avoid any of those.
And I guess we have to say people should be careful of excessive alcohol use, since I did read yesterday, at least in the San Francisco Bay Area, that alcohol use is up 42% since the shelter-in-place order.
Not very surprising. Not very surprising. Yeah, yeah. Well, again, I think it's important for folks with CF to make sure that they're following the general recommendations about alcohol interactions with medications and avoiding, that if they can. Same would apply to vaping and, the usual kinds of recreational drugs that are out there in the community.
Absolutely. Yeah, I was outside
you
the other day. Pardon?
You raise an important point. I don't know if Dr. Scher has been talking about this in her support groups, but a lot of people will be turning to pharmacology to help get them through this. And that has some benefits, sure, but it also has some risks, and those things need to be talked about.
Right. I think it's interesting. I saw that Greenland has banned all alcohol sales because of an increase, and it's quite tragically because of an increase in domestic violence and the correlation there. But I do think that it's fascinating that both dispensaries and liquor stores are considered essential businesses in this day and age for people to cope. So.
Yeah.
Let's see, you had mentioned about that's just too soon. So is the CFF, do you know, are they tracking, trying to be a repository for information about those with CF and COVID-19 who have contracted COVID-19?
Well, the CF Foundation for sure is involved, and I know they've set up a web page with frequently asked questions and responses. I've seen a video from Mike Boyle, who's the president. Definitely another great source of information. And I don't know if anything beyond that is being done in terms of structured intake of data on patients. I wouldn't be surprised, but I haven't heard about that personally.
Are there any instances of medication shortages?
I'm not aware of that. I haven't heard about that. The medication shortages really are in some other areas that have to do with intensive care. Some of the drugs that are being proposed are out there as treatments for COVID, which are not, luckily there's no overlap with CF drugs at this point. So I don't think there's any threatening. I do think Vertex has specifically assured the community that they have an adequate supply of Trikafta and other modulators. So hopefully that won't be an issue. But this came up I think last time we spoke about the fact that people should try and get an adequate supply. This is not a short-term issue. We're all going to be in this for months to come. So it's important to make sure that you don't run out of your CF meds from whatever reason.
Right. And we had talked about this last week about advocacy and CFRI. We're continuing to follow up. I mean, it's very complex in the states, with each state having their own insurance commissioner. Some are elected, some are appointed. Some people have already made mandates related to the Medicaid programs, but not private insurers. Some private insurers have done it on their own. So it's just been this incredible patchwork quilt. And so we are actually, even today, have meetings around how to see if there's some uniform mandate that could be put in place so that everybody can get multiple months of their medications in advance. So we will keep everybody posted about that.
Yeah, and I think it's a kind of microcosm of the healthcare issue in the US in general. We have a very uncoordinated, fragmented situation. So you're left dealing with many different sources of medication, of reimbursement, of distribution, and that makes it very difficult to have a uniform outcome. Right?
Right. So it takes a little more sleuthing work to see about how to make change. When the world is deemed safe for the general public, should the CF community and their families or caregivers still stay quarantined at home for work and school until there is a widespread vaccine?
I suspect that that's likely. There's been a lot of increasing discussion of what so-called phase 2 might be like. Let's say we get through the apex and things are going down and we bent the curve and we're sort of starting to come out of this. How do you reopen the country, right? How do you get things back towards normal? And I think for That'll depend on the availability of widespread identification of truly infected people through testing. Also through people that have become immune through blood tests to see if they've developed immunity. Those are two things. We're not close to that. Hopefully we'll get there over the next few months and be able to then target areas, but also groups of people. So the highest risk people may be advised differently than the general population. So while some people may be going back to work if they've already been infected or if they're immune without having gotten sick, you still have the vulnerable subpopulations. And I think CF is likely to remain in that category. So my guess is that without a effective treatment or vaccine, we're still going to stick with the recommendations about isolation or social distancing for the CF population in general.
So the question of immunity was a perfect segue because there was a question about antibodies. And obviously we're so new into this as a nation. Are other countries a little ahead of us, China specifically, to be able to test for antibodies and have any proof whether they're long lasting, sort of like chickenpox, or short lived?
So there are now some studies coming out. Again, first from China, but we'll see others from other places too, that are defining what happens to the immune response when you get infected. Certainly antibodies are produced. Some of these antibodies are so-called neutralizing antibodies. They will prevent the virus from getting into cells. We don't know how long they'll last at this point. I've heard Dr. Fauci say, and I think he's generally a pretty reliable guy, based on his knowledge of all the other viruses that have been a problem. Exposure usually does result in long-lasting immunity for certain types of virus, of which this is one. So the expectation is that immunity will tend to be long-lasting, but we don't know that. We'd have to do the studies, and those are going to come in the future. The blood tests, the serologic tests for immunity, are just now being rolled out from the manufacturers. These kits have been developed, like everything else with this disease, over a couple of months. So I was very, very pleased to see that one company called United Medical is going to do a serologic test of the entire population of Telluride, Colorado, in cooperation with the government, to look at that exact question: how many people show evidence of antibodies, i.e. being exposed and developing what we hope is immunity, and then seeing how they do. It's likely that these tests will be used to allow people to get back to work. I think that's one of the markers of success that we'll have to follow.
And is Telluride chosen because there are no known cases there?
I don't know exactly why Telluride, Colorado, of all the places in the country, has become the first test site. But the good news about that is, it's relatively isolated up there in the Rockies. And so you can actually get at the entire population and get a really good snapshot when the study is done. And they're just starting it now to see how widespread exposure has been and how many people have developed antibodies to coronavirus.
Fascinating.
Yeah.
And if you have to do research, Telluride's a pretty good place.
Maybe that's why. On the side, maybe not.
Does the COVID-19 virus mutate?
Yes. The good news is that the mutations have not made it worse. If anything, they've made it less severe. But there is a very interesting website for the science nerds out there called nextstrain.org. And if you go to that website, you will see an incredibly sophisticated website that looks at the evolution of the virus from the first samples that were taken in Wuhan up until a few days ago. And there are literally thousands and thousands of samples that have now been analyzed, and they can look at every particular genetic change that's occurred. So there are different sequences in the virus from different parts of the world. So, and we know in general that these RNA viruses do mutate pretty easily. Luckily, most evolution is in the direction of becoming less virulent. We can't rule out the possibility of the opposite, but that doesn't seem to have happened so far. So that's probably good news.
And with those mutations, does it make it more difficult to develop a vaccine, or is it all encompassing in general?
Yeah, that's a good question. So the vaccines will have to rely on parts of the virus that tend to be stable. And the candidate that's really in most people's mind is this spike protein, this S protein, that or parts of it that actually interact with the cell receptor. Because if you can block that, you're home free. You prevent the virus from infecting cells. So this has been a problem with flu, of course. That's why flu vaccines change every year. But flu is a different kind of virus and is more mutable in some areas. So hopefully we will come up with a vaccine that applies to all the different variations and stays stable. But nothing is assured. It's still too early in the game to know whether we'll need to be doing iterative vaccines as we do with influenza.
Got it. Wow. Our 12-year-old daughter with CF had the longest, excuse me, longest and worst flu we've seen her go through this past January and well into February, and she tested positive for A strain influenza at that time. What strain is COVID-19?
So COVID-19 is a different family than influenza, and it's one of these beta coronaviruses. There are, I think, 4 known other members of that family of coronavirus that cause common colds. So COVID-19 is a different strain than those, and has little in common with any flu type virus. The daughter who has influenza A, I don't know if she was tested for COVID-19, but it does bring up an interesting point, which is now we're becoming aware of the fact that co-infection does occur. So until the test kits for COVID were available, and in many places they're still not available, but in those where testing is now widespread, you can test for both common respiratory viruses like flu or rhinovirus, the cold virus, or RSV, et cetera. But you have to do a separate test for COVID-19. And unless you do both of those things, you don't know about co-infection. These studies have lagged a little bit, but now we know that co-infection can occur and it may be more frequent than we think. So somebody can have both influenza A. Her daughter may have had influenza A. Well, she did. They know that from the test. Also, and unless that was tested for, we don't know if she was co-infected. We don't know if co-infection makes things worse or not. There's a lot of unanswered questions about that, but it's pretty clear that you can get infected with multiple viruses, including COVID-19 plus influenza or some other virus.
We'll never want to leave our houses. Somebody asked, have there been any updates on, is it ACE2 receptors, or do you say ACE2?
Yeah, I don't know. I think ACE is okay. Which is that's the receptor on cells. It's on lung cells in the air sacs, in particular the pneumocytes, type 2 pneumocytes. Yeah, there is some information, and a review of this was recently in the New England Journal, where we know that this receptor can be affected by other diseases and other medications. What we don't know is whether increasing or decreasing that receptor or using certain drugs that affect that receptor help or hurt. And that's still being sorted out now. But it has led to recommendations from several professional organizations in the United States and also internationally at the level of the World Health Organization that people taking these medications for hypertension, which is where they're mostly focused, don't discontinue them. There was some fear that, if you were on a medicine, the so-called ACE inhibitor medication, that it would make you more susceptible to infection or worsen the infection. At this point, there's no strong evidence of that, but more studies do need to be done. So that this is an area that is going to get a lot of further study, and it's still pretty ambiguous at this point. With the recommendation to stay on your ACE inhibitor if you're treating, or the other medications that are used to that affect the system to control hypertension, don't discontinue them. The other thing that's come up, and we spoke about this last time, was diabetes. There's some evidence that the ACE receptor is increased. What the relationship there is to high blood sugar is not clear, but people with diabetes do seem to have more expression of the receptor. And this may play into the fact that diabetes has been found as one of the comorbidities that may make COVID-19 infection worse.
Let's see. You're working your way through a very long list here.
Yeah.
We've already gone through page 2. Okay, back to the food issue and how clean is our food. Have there been any studies to see if the virus is present on foods purchased at the supermarket? As a person with CF, should I completely avoid going to the grocery store?
I don't think that I've seen studies where they actually look at that specifically. The studies that have been done, as we've talked about, really have to do with how long the virus genetic material may last on surfaces. And they have looked at plastic and cardboard, and both of those, the virus can exist on, and we don't know how infective it is, but there's some evidence that it could be infective, but at very low levels, there is a drop-off over time. That's very significant. But it is detectable up to 3 days for plastic surfaces. So based on that information alone, the recommendation in general would be to disinfect the food you bring into the house. And that can be done pretty easily by washing it and then disinfecting it. And the best disinfectant, here's a CDC webpage, which I find is very helpful. I don't know if you can see that, but it's labeled Cleaning and Disinfection for Community Facilities. It's part of the CDC COVID-19 website. And it goes through things. I was interested to learn that they list 351 different disinfectants that are out there. But really, the simplest thing to disinfect is simple bleach, and to dilute bleach, check the expiration date on your bleach, make sure it's still active, and then just put 4 teaspoons into a cup of water. And that becomes a good disinfectant. First you wash off and then you disinfect, and you can use that pretty safely.
Oh, that's very useful. And we'll make sure we have that up on our site as well. Is it best to avoid eating raw fruits like strawberries or apples?
No, again, I think as long as they're cleaned, first of all, the likelihood that when you get them off the shelf, there's going to be a problem is low, but we can't say it's zero. But, so if you do take it in and want to eat it, then I think it would be a good idea just to clean it, wash it off, and then it'll probably be safe to have.
Excellent. And the final question of the morning, what is the best way to sterilize or disinfect our equipment like nebulizers and spacers for inhalers when we do not have any true sterilization options available in the home? I'm not sure.
Well, again, folks with CF and their families and loved ones and caretakers have known for many years that they need to disinfect their equipment, and particularly things that are used for aerosol treatments. That's really can be problematic. So we know that heating to approximately 140 degrees kills SARS, and it hasn't been specifically looked at for COVID-19, but they're closely related viruses, and I'm pretty sure that would also do the trick. So the usual, heating and drying that you would do with your nebulizers, cups, and so on, would be sufficient. So beyond that, I don't think that, as far as things like inhalers and things that you're not putting in, in the washing machine and dryer, again, disinfecting is probably the best way to go.
And this is good.
If you're not exposing them, as long as you're doing good hand washing before and this gets back to hand washing. So again, before using your medical equipment, hand washing should just become a natural habit before using anything. So the more often you do that, the likelier it is that you're in the clear.
And, I think as a community, we are so ahead of the curve in terms of hygiene, hand hygiene, social distancing, all those things. But this really has been a reminder that, we all slip and it's good to refresh your memory about the many ways to sterilize and disinfect things.
Yeah, but if you think about the learning curve the rest of society is going through, this is one of the bizarre benefits of having CF or being associated with someone that has CF. We're there already, pretty much.
Mhm. We have a lot to teach the rest of the world.
Anyways, yes.
Yes. So that concludes my list of questions. Were there any other points or facts that you think people should be holding close today?
Just to keep a lookout for the CDC statement on masks, because I think that would be the biggest policy change that might be coming up in the next day or two. I would expect them to, since there's all this expectation, we should have some kind of announcement very soon about that. So that would be the main one.
Great. Well, again, I cannot thank you enough for taking your time and sharing your expertise with the community to keep us informed. We are all very grateful.
Thank you. I'm happy to be able to try and help out. Thanks.
Thank you. Bye-bye.
Ciao.